I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. It is my absolute pleasure to bring in one of my favorite people, Dr. Mendez. Dr. Mendez is the Chief of Ambulatory Pediatrics at Richmond University Medical Center. And when I had children in the age that pediatricians watch them and take care of them, she took care of them. And she is absolutely one of the best pediatricians I know, one of the brightest ladies I know.
Thank you.
And her energy and her love for patients really comes through everything she does. So, Anne, I want to say thank you for coming. And we're going to do What's New in Pediatrics.
Okay.
And we're going to talk about, we're going to get started. We've had a series of pediatrics, on pediatrics. And we talked about different parts of it, growth, cognitive development, physical development, and everything has always gone back to the general pediatrician. Very few people can get to their subspecialist without going through the general pediatrician, which is absolutely right. So the first question is, tell us about pediatrics for everyone. What's the training of a pediatrician?
So the training of a pediatrician is a medical school. That's a 4-year endeavor. I went to Albany Medical College in New York. Then you go to do your residency. I did residency in medicine and pediatrics at Staten Island Hospital. And then once you graduate from residency, then you can start practicing as a general pediatrician.
So you're in pediatrics, and I think, as I've said in different shows, and I'll say it again, all medical students want to be pediatricians at one time.
Yes.
Because it's so much fun to watch the kids, and especially with such an overwhelming number of pediatricians are kind people. They're sitting there, they're patient, they're with children who really can't give them answers, and they're able to come up with diagnosis, and they have to deal with the parents. So it's a very difficult aspect. And then somehow some people go into pediatrics, which I really do respect so much, and then some people go into different fields. I've gone into adult neurology, and I actually was thinking about being a pediatric neurologist for a while when I started. So the idea about going to your pediatrician, adults sometimes skip doctor visits. When you have kids, you really can't skip pediatric visits.
Absolutely.
And really give us an idea from the time a child is born. That we think about going to the pediatrician as having a stick in your mouth and down your throat or something put in your ear. But that's not, you don't just go to the pediatrician when you have a sore throat or an earache. No. There are things that are so important for our families to know and our viewers to know. Our viewers are so marvelous. And all the letters that you guys send me and emails now are really just so wonderful, being both on cable TV and on YouTube. We see so many people from around the world actually watching our show.
Oh, wonderful.
So the idea about why do you need to go to your pediatrician? Could you miss a couple of appointments? Everyone's busy. So tell us why they should go.
So kids are growing, right? Unlike adults. They're growing physically, they're growing mentally, they're growing socially. So the well-care visits are really important to have. And the younger you are, the more well-care visits you have because the growth is so fast. Just look at the difference between a newborn and a 3-year-old. So between the ages of newborn and 3-year-old, you have many visits. We see kids at birth, at 2 days, at 2 weeks, at a month, 2, 4, 6, 9, 12, 15, 18, 24, 30, and 36 months.
Wow.
And why do we do that? That's a lot of visits. We do that because kids are growing so fast that we have to make sure that they're growing normally, that there's nothing that we have to address. And when you come to the pediatrician for your well-care visits, we're looking at many aspects. First, you get weight, you get a height, you get vitals. So just as you had discussed in your previous program, the weight and height tell us how they're growing physically. When you're growing so fast, things can go wrong, and we can catch it on time, and we can see what we need to do and work it up. It's not that many kids are having abnormalities, but pediatrics is like finding a needle in a haystack, right? So you have all these healthy kids. You don't want to miss that one kid that has a problem. So the same thing for parents. If you don't bring them in, you can't tell when it's too late. So well-care visits are there, especially in those first 3 years, to really look at growth in general, mental, development, and physical. And that's what we do. That's why at your well-care visits, you're having not only your weight and height, you're having an evaluation of your development of the child, you're having an evaluation of their physical status, you have an evaluation of the family and how can you help them to nurture this child in a healthy way. So those are the things that we do at a WellCare visit.
I think it's amazing. We work at the same hospital, Richmond University Medical Center. When I see the pediatricians, some part of the hospital system, some private pediatricians who come in, seeing babies who are a day old, 2 days old. So they're coming in and they're seeing their first visit with both the mom and dad, of course, and them. What are they able to see as a neonate? What are you looking for?
So in a newborn, we're looking to see that they have they're transitioning well from being in the womb to being outside of the womb. So 99% or more of kids do fine, right? But there's a small percentage that can have a cardiac problem that might not be diagnosed, that takes time to show. They might have problems with their bilirubin, they get yellow, and that can affect, if it's high, the brain, so we have to make sure that that's okay. We have to look at how they're feeding, right? Because at that age, weight loss or not gaining enough weight is absolutely crucial to the brain development and to the development of that child. So that's why we look at. We look also how the families are adapting to the child, how are they feeding them. We help mothers get through the process of breastfeeding, which is the healthiest thing to do with a child, but also support mothers who might not be able to breastfeed. It's not a test, I always tell them, all right? It's not a test. You're a good mother if you breastfeed, and it's better to breastfeed, but some people have some trouble because of medical issues. So those are the things we're looking at. We're looking also at how the mother's coping, right? We even do now, at the first visit, we do an evaluation of the mother's, depression, make sure they're not depressed. We actually have an actual tool that we use to look at that. So we're looking not only at the child, we're looking at the whole family, and we look how can we help them shepherd through the first month of life to make sure that the child has adapted from being in the womb to being outside of the womb in a healthy way.
And as you mentioned, developmental milestones, of course, and if someone is sick, they'll call their pediatrician. But let's go into one thing: why children cry when they see me in a white coat. So if mom comes to me because I'm a neurologist, has a headache, and she brings her 2-year-old, and mom will tap me on the shoulder and say, "If you take your white coat off, the baby will stop crying, and then we could talk about your headaches. If you don't take your white coat off, the baby won't." So the idea about immunizations, it leaves certain people, again, we're not scarred, because again, I'm a very big advocate of immunizations.
Yes.
So tell me a little bit about the protocols for immunizations. And again, so many people have a lot of different opinions about them. So let's try to bring everybody up to the real science of immunizations.
So first, about the white coat, I haven't used a white coat in the office for 17 years. So that's what I would suggest that you do if you're seeing a child.
Okay.
Don't wear a white coat. Number 2, immunizations. So immunizations are crucial. So this idea of the child adapting to the life outside of the womb, right? It's a process that takes, especially in the first year of life, takes time and takes adaptation, not only of the body, but the immune system. So children are exposed to thousands and thousands of antigens in their environment.
Those are different proteins, different infections,
different microbes,
right.
But there are super microbes, okay, that their immune system is not adapted, or even an adult might not be adapted to deal with, because they are so aggressive, and we know they can either disable a child or kill them, all right? And people don't remember because we've been vaccinating people for over half a century, right? But polio, the first vaccine, right? Polio used to cripple people or kill them. We had Roosevelt as a president who got polio as an adult, right? Didn't get it as a child. So why don't we see polio? Because we vaccinate, all right? And something like diphtheria, a bad infection of the throat, why don't we see it, which used to be a very big problem with mortality and morbidity for kids, for infants, because we vaccinate. Tetanus is deadly. There's no cure for tetanus, right? And children, adults who were exposed to tetanus through the soil or through cutting themselves with metals in the past, before immunizations, used to die from tetanus. Well, we don't see that anymore. So those are superbugs that can really, it's not your regular, but it's superbugs that we have created immunizations for, because we're trying to avoid people from getting the diseases that were, as children, either making them very sick, disabled, or killing them. So all of our first-year immunizations do that. That's what they were created for. And we vaccinate at the beginning of life with hepatitis B, because hepatitis B is one of the 2 vaccines that protects against cancer, and it's most effective at birth, because even if no test is 100%, but a mother can give a child hepatitis B if they have it. We test for it, might be negative, but there might be a small amount that we might not catch with tests, because no test is 100%. So if you give the hepatitis B vaccine at birth, then you are decreasing the risk of transmission of hepatitis B from the mother to the child. And then we complete the vaccination at 2 to 6 months. Before that, we don't give vaccines because they're not effective in creating antibodies at that point. So we have tested them and seen that certain vaccines you give at 2, 4, and 6 months that can prevent those diseases. And for 2, 4, 6 months, it's usually diphtheria, tetanus, pertussis, polio, hepatitis B, Haemophilus influenza. It's a bacteria
which causes meningitis.
Which causes meningitis. It used to cause, we don't see it anymore because of vaccination, and pneumococcal against pneumonia. And nowadays, the newer thing is the RSV vaccine, which now we're using for the first time, and COVID and the flu at 6 months.
So I think it's amazing because, as you said before, the babies are born with this innate immune system to anything. So if a 1-day-old gets a cut, the immune system is set up. But we're all set up for this thing called the adaptive immune system. And that's where, even in my specialty as a neuroimmunologist dealing with MS, we always are trying to manipulate that adaptive immune system. That's what all these vaccines do. They basically give something that looks a protein or an antigen that makes the body think they're infected, but they're not, and builds up the antibodies.
Exactly.
And some you can keep for a longer time than not. Tell us about one that really strikes me, because it really does overlap what we do, is chickenpox.
Yes.
So the idea of shingles as an adult, if you ever watch the commercials, say
Yes.
if you're over 50, you probably had chickenpox, 90+% of people.
It's harboring in our bodies like the like the
They used to have
commercial.
chickenpox parties where mothers, families wanted everybody should get it just to get it over with when they're very young. 'Cause
Yes.
it's a lot worse when you're older. But it's really changed. The rate of shingles has gone down in younger people because of it.
Because of the vaccine.
So tell us about chickenpox vaccine.
So we discussed the vaccines given before 1 year of age. And really, at the beginning of life, kids can have antibodies from the mother, but they wean off. And, one of the reasons why we start a lot of vaccinations at 2 months, when they're starting to wean off. Now, live vaccines, like MMR, measles, mumps, rubella, and varicella, they're not valid if you give them before 1 year, because with live vaccines, you might still have some antibodies from your mother, and if they interact when you give the vaccine, it makes it null. That's how live vaccines work. So that's why varicella and MMR are not given before 1 year of age. They have to be one.
MMR is measles, mumps, and rubella.
And then the varicella. So we give them at 1 year of age, because that's when they won't be canceled by the mother's antibodies, and they're effective. And we give it at that age because being exposed to varicella, for most kids in the past, people did okay, but there's a small percentage of kids who can develop infection that can affect their lungs and their brain. So, one child not doing well is one child too many. Plus, it avoids getting shingles when you're older.
Absolutely.
Right? So we do give varicella at 1 and then between 4 and 5 years of age. The same thing with measles, mumps, rubella.
So tell me a little bit, what do you see most in running this ambulatory center? You have pediatric residents. You teach them, which is wonderful.
We do. And medical students and PA students and nurse practitioners.
Everybody comes in.
Everybody comes in.
And everybody takes care of the children. And tell me, what kind of things are you seeing most now? Populations have changed. We're in an inner city. We're seeing a lot of people who are coming from outside the United States. What kind of things are you seeing in the clinics that we might not be thinking of, routinely?
Yeah, so we do see a lot of kids who are new immigrants, and contrary to popular belief, I don't really see any big new diseases that they're bringing from anywhere. That's the first thing. For every new immigrant, we check if they have antibodies against hepatitis A, hepatitis B, hepatitis C. We check HIV. If it's necessary, we check ova and parasites in their stool. We check for tuberculosis. And it really has been
Those are unusual that we think about the third
Exactly.
world countries.
Exactly, or developing countries.
I'm sorry, there's always a politically correct term. I'm sorry, you're right.
So so we don't really see anything out of we might catch one ovarian parasite rarely. Being exposed to tuberculosis is the most common. What we treat, we get a chest X-ray if they're most of them are negative, and then we put them on prophylaxis for tuberculosis. That's the most common, but also not extremely common. In terms of all populations that live in the north side, right, which are that's the population that's the lowest in socioeconomics, in resources, in political advantage or any advantage. We do see, in terms of diseases that we see in general, is asthma, obesity for all children. It's high in our population. And mental health has come to the forefront for all of our kids of all ages for many different reasons. I think the pandemic and the isolation really exacerbated what was there already. And the displacement of some of our patients also, and the fear for their parents also creates an anxiety that we see palpable.
So tell me, when does a pediatrician, who and this is wonderful that we're talking about the psychosocial issues that are involved, when do you feel comfortable treating these things? When do you have to give them medicine, or is many a time medicines are not required? When would you think that someone needs to see a psychiatrist? How does the pediatrician make that decision?
So the American Academy of Pediatrics for the last decade has really put into effect making mental health something that pediatricians are responsible for, right? The first thing is screening, all right? So at the beginning of life, we screen the mother for depression. We do surveillance at every visit to make sure that the family see what the family needs are, and we, in our own practice, we advocate with the community-based organizations that can come in and help our parents to create a more stable situation for them. And then at the age of 5, and we do developmental evaluations, right, that you discussed before.
Yes.
At the age of 5, we can start giving an evaluation to parents to kind of like do mental health evaluation at the WellCare visits, which we try to do most of the times because it's hard sometimes in a practice that's very heavy. But for our kids who are preteen to 21, we have in place for all WellCare visits a screener for depression, anxiety, bullying, eating disorders. And it's amazing to me how many times it's positive. So we have in place a protocol to connect them to mental health, and we're lucky enough that we site on mental health as part of our hospital, and we transition them from, we first do the evaluation, we determine what is the severity of the depression or the anxiety, making sure first that they're not at risk of hurting themselves or hurting others. So there is a protocol for that. There's a protocol for those who are stable. And then, we follow them until they're seen by the psychiatrist if it's not an emergency. And depending on how fast they're going to see the psychiatrist, we have taken training in when to start medication for our patients. Also, there's a resource that you can call New York State where you can have one visit with a psychiatrist. We do that. I've done that a few times already this year. And then with that one psychiatric evaluation and the patient is stable, and I start the medication until they are connected to a psychiatrist, which can take 2 to 3 months.
Just to go on another topic, as our time is coming to the end, tell me about sports. So many of our kids go to sports.
Sports physical.
Right. The sports physical, the camp physical.
Yes.
But sports specifically. There's a lot of pressure on the kids, and maybe we can even go sport by sport. I've lived them all with my son. The baseball with the heart guard, with the little with the thing they put on. The pediatrician really is the person who's involved in this. So tell me a little bit about what your thoughts are about it. Kids doing some contact sports. As a neurologist, I really don't want them getting. I said you could do anything you like, but just don't hit your head.
I know. So listen, like with everything else, parents have the last say with their kids. If I had a child, I would not want my child to be in football hitting their heads. But every family has their own culture, and what we have to make sure when we do that sports physical is that the child is physically able to do the sport. We do talk to them about head injury and to come in immediately if there's a head injury, because you have to follow a protocol to avoid getting into the sport too early, which you know better than me, and that's something that that we try to emphasize for those kids doing football or any other contact sports where they can hit their heads.
But it's important. What about the cardiac issues? And on Staten Island, there was an issue a few years ago, of someone having a cardiac event, and it was actually with a very prominent family, and now they're having screenings, echocardiograms,
So
EKGs. And what's your thought about all that?
So the main thing with sport physicals is to get a good history. If there's a family history of any early heart disease or any early death with unknown why the cause was, you need to get a cardiologist involved. You need to do a good physical, and you have to know the children. If there's any hint of a murmur or anything with their heart, you should send them to a cardiologist. But in general, most kids do not need an EKG, they don't need an echo, and they don't need a cardiologist. I'm lucky to have my teenagers that I've seen since they were children. I would say like 90% of my teenagers I've seen since they were children. So knowing the history is important, knowing the family is important, and knowing that if they've ever had symptoms with, I go over also their symptoms. If anyone has ever had symptoms with doing exercise, that is absolutely a need to get a cardiological evaluation.
Tell me about your team. You mentioned you're
Yes.
training residents, nurse practitioners, physician's assistants, medical students. What do you try to impart to them when you teach them? And again, you're such a wonderful teacher, and your reputation is so stellar on the island and in our hospital. What do you try to convey to new doctors, and what do families need to know? You think about our viewers. You go to the doctor, you sort of have an idea of what's going to happen because you've been a patient for a period of time. What do you try to teach some of these new healthcare providers in their especially in pediatrics?
So first thing I would love to convey is about the patient, not about us. Right? Because when you're training, you're so focused on, I have to know this, I have to know that, it's about me when you're training. So the first thing I tell them is not about you or me, it's about the patient. So all of our care should be patient-centered. It's about keeping ourselves, as much as we can within our own means, up to date with the things I should be doing, and really listening to what patients need and their families. We're not perfect. We might not be able to accomplish that all the time, but that's our goal.
Now we're going to go into a couple of other topics. Asthma. Childhood asthma is such a common thing. I mean, I see people with inhalers all over the place, and then you sort of read the literature and say that people shouldn't be using inhalers that much. Tell us a little bit about asthma. And if you have a kid who has asthma, who's afraid of going into sports, who's somewhat stigmatized at school, tell me about it.
So one statistic that I remember, the last summer Olympics, 80% of the athletes, I think, had asthma, and they were well controlled. So think about asthma I've been doing this for 25 years. The change in how asthma treatment has improved is amazing. And if the main thing with asthma is treating it correctly. You shouldn't use albuterol inhalers all the time, but your preventive medication to our puffers you should use. So the main thing is the goal is to be symptom-free and to be able to exercise, not to sit down because you're having asthma. So my advice would be, if your child has symptoms of asthma, get them seen, get them evaluated, know their severity, know what the treatment should be, and follow it. Because if you follow it, they will perform at the same level as any other kid.
So I think someone asked me before we did the show, like, what kind of questions do you ask? And I'm thinking to myself, as a parent, here are the questions you ask.
Yes.
Your kid has a cold, a little sore throat. Now, half of his class has the same sore throat.
Yes.
We used to name the infection after one kid in the class who had it first. not to be anything bad, but just say, well, that was this kid's cold. When do you go to the pediatrician?
So nowadays it has changed a little bit with the flu and COVID.
Yeah.
People want to know what the kid has because the school is not letting them back if they don't know what the kid has. My approach is, if the parent feels that they should see the pediatrician, they should come in because the parent knows their kid better than anybody. if the kid, if you want to come in, I will see you because you know your child better, and you might have that instinct that something's wrong, that I should look into it. And I do get more requests to do a testing for flu and COVID because there are decisions to be made about work, about treatment, about how long do you quarantine. So those are valid questions that I would address to the family on an individual basis, depending on what they do for work, if they're in daycare, if they're in school, and the severity of the symptoms. But if a parent feels they should bring the child in, they should. If a child is not eating, not drinking, vomiting, high fevers, not acting normally, absolutely they have to come in to see the doctor.
A lot of parents have thoughts, and as a parent we have thoughts too. So when a child is sick, so often there's a reflex to put people on antibiotics. All kinds of different ones, whether Z-Pak, amoxicillin, we all know the names. And we try so hard in the medical field not to treat people with antibiotics, especially like that cold that I mentioned that everybody in the class had, because it goes around and it's like almost, it behaves like a virus, obviously. So tell me a little bit. Two things. One is, how do you decide whether you're going to use antibiotics or not? And the second question is, how do you tell a mom or dad who really wants their kid on an antibiotic that they really don't need it?
So I'm going to turn the coin the other way. Now that we can check with viruses, the parents wait a little longer if you tell them what virus it is. So I think that has helped us. Taking antibiotics when they're not needed only harms someone. So we give it when it's only needed, when we know that there's really a bacterial infection. And I will speak to the parents, and see, when they're so insistent, am I missing something in the history where they're sicker for longer? But in general, I think if you explain to parents, this is a cold, we're going to watch the child, you have access to call me, or I'll call you. When you create a communication to follow the child in some way, I think it really goes a long way in helping parents wait to see if they actually need antibiotics.
You made a wonderful point a few seconds ago that I'm still sort of digesting. When I was in school, there were kids who would come in with 100. They were tough it out because there was a test there. They had to be there that day with a fever, runny nose. Are you seeing this change now in this post-COVID era?
I think so.
Where kids are not going to school when they're sick.
Yes, I think it has changed, and I mean, even though COVID has gone down, there are some, as you see more than me, some people who get very sick from it. A parent, a grandparent, so a teacher, a principal. So no, I think it's made us all more aware of really being careful when people are sick, and having the courtesy of wearing a mask, which we didn't do in the past. We used to see people on TV from other countries and be like, oh, what are they doing? Now we know it works, and really staying home and not getting other people sick is something that I think we've accepted more as a society.
And with the virtual options, in the schools being much more involved.
Not missing work.
Right, and I'm sure you write a lot of notes, and it's important. It's really crucial for all of us, not to try to get less and less exposed.
Absolutely.
And I want to say thank you. I want to also mention that you're going to be president. You are president-elect and soon to be president of the Richmond County Medical Society, which I was a president of a number of years ago. Yes. And your dedication has really is tremendous. It is an absolute honor to have had you here tonight.
Thank you.
And so concludes our pediatric series. Hopefully next year we'll talk about some other issues in pediatrics. Thank you all and have a wonderful night.